My name is Cecile Katzoff, and I am Vice President for Practice Management and Consulting Services for the American Gastroenterological Association. Today we will be showing you the first in a series of videos on practice management issues. This video is Living Without Consultation Codes. Prior to January 1st, 2010, most physicians in specialties, when they saw patients for the first time at the request of another physician to evaluate them for a specific problem, would use the consultation codes, which were 99241 to 99255. However, effective January 1st, 2010, Medicare made the decision that they will no longer pay for those codes, and we're going to talk about the codes that you would substitute for the consultation codes, both in the outpatient and the inpatient setting. The reason why Medicare decided to eliminate payment for the consultation codes was because they were often misused or inappropriately documented. The change to the codes that would replace the consultation codes will be budget neutral. Medicare has announced that they will adjust the RVUs for the new and established patient office visits and the initial hospital and follow-up subsequent hospital visits to accommodate the change in reimbursement for the consultation codes. So effective January 1st, 2010, you would no longer bill the outpatient or inpatient consultation codes to Medicare fee-for-service or any other payer that has informed you that they will no longer accept the consultation codes. For the Medicare Advantage plans, each plan will make its own decision whether or not they will continue to accept the Medicare consultation codes. So for all other payers, unless you have heard otherwise, you can continue to use the consultation codes. In place of the consultation code for a patient who is new to your practice and presents as an outpatient, you would use the new patient visit. This is for a patient that has not received any face-to-face service, or face to any other body part for that matter, from a gastroenterologist or a mid-level provider in your practice for any reason in the past 3 years. The codes are 99201 to 99205. The level of service must reflect the documentation in the medical record as defined by the 1995 or the 1997 documentation guidelines. For a patient that has been seen or received any face-to-face service from anyone in your practice of the same specialty for any reason within the last 3 years, when they present to your office, you would bill them as an established patient visit. That's 99211 to 99215. Other outpatient services, for patients that are seen in the observation unit, if you are the physician who has admitted them to observation and would ultimately admit them to the hospital if they require hospital admission, you would bill 99218 to 99220. If you are not the physician that would ultimately admit the patient to the hospital and you see them in the observation unit and you have not provided any service to this patient for at least 3 years, or anyone in your practice has not provided any service within at least 3 years, you would bill a new patient visit. If you have provided a service to the patient within the last 3 years, you would bill an established patient visit. If you see the patient in the emergency department, you would bill the emergency department visits, which are 99281 to 99285, and there is no time restriction for those codes. For an inpatient, the first time you see an inpatient during that particular admission, you would bill the initial hospital care code, 99221 to 99223, regardless of whether you've seen the patient before and regardless of whether you've provided any service to that patient prior to this particular hospital admission. If you are admitting the physician, and you are the admitting physician, you would add the AI modifier to the code. The level of service that you select would be determined by the documentation in the medical record, again using the 1995 or the 1997 documentation guidelines. If your documentation does not meet the criteria for the lowest level hospital admission code, 99221, you would code a subsequent hospital visit, 99231 to 99233, again, depending on the documentation in the medical record. For follow-up care after that initial evaluation, you would build the subsequent hospital care codes 99231 to 99233. Shared services. Prior to the elimination of consultation codes, consultations, whether they were provided in the office or in the hospital, could not be shared and had to be billed under the name of the provider of the service. However, now with the elimination of consultation codes, for the initial hospital care and subsequent hospital care codes, they can be shared between a mid-level provider who is employed by the practice and a physician in the practice if both see the patient on the same day. If both see the patient on the same day, the physician can bill under his or her own provider number the combination of the services provided by the mid-level and the physician as documented in the medical record. If, however, the physician does not see the patient on the same day, then the service must be billed under the mid-level provider's number at the level of service documented in the medical record, and payment for the service is at 85% of the physician fee schedule. If you have any questions regarding the change with the elimination of the consultation codes, please contact me at 301-941-2639 or via email at ckatzoff@gastro.org. Thank you very much.